Yeah, so my research is in HDX is mostly about methodology for predicting risk of complications for cancer patients. So I have a short outline of the presentation. The first part is just the research presentation, and then some questions and hopefully informative answers. And then, but yeah, if you have, Matteo, or if you already have questions in between, then feel free to interrupt.
Okay.
Yeah, so in the talk I will focus on, or in the project, we are focusing on head and neck cancer patients who receive radiotherapy. So that means that patients that have a cancer in either the nose or the mouth area or in the throat. And the most common complications or long-term complications are that patients experience after several months still, for example, dry mouth, or have difficulties with swallowing, and in severe cases even become dependent on tube feeding, so they would not be able to, or they only able to eat liquid food, which has a big impact on their quality of life as well. So in the planning of this radiation treatments, there's two factors that are really driving the treatment. So the first is that the cancer should be cured, and this is generally done by making sure that enough radiation is assigned to the location where the tumor is, to those regions where the tumor is. And the second objective is to keep the complications to a minimum, and this is generally done by trying to avoid radiation around in the areas around the tumor as much as possible. So there's different techniques to, so here on the right you have a plan, for example, and you have different techniques that determine what this plan can look like. And one of the techniques for making such plans or giving radiation is proton therapy, that is now of interest in the HDX project. And the advantage of this technique is that in some cases, or it's quite precise at delivering dosage to a certain location without delivering too much dose to other locations. So this is a bit in contrast with standard radiation therapy, where you often also, where it is more difficult to prevent this unwanted radiation to areas around the tumor as well.
So, can I interrupt?
Yeah, sure.
So on these two pictures, the standard radiotherapy and the proton therapy,
yeah,
what is the signification of the different colors? What do we see here? What is important to understand of these different photos?
Yeah, so in these pictures, so this is just a slice of just a slice. So it's of the head, but there's on the right you have the red. More red means higher radiation dosage, and toward the green it is a lower radiation dosage. And if there's no color, then no dosage was planned. So what you can see on the right is that so here there's the target areas are delineated. So this circle here and this one, and that's why there's so much red or dose assigned there. But then there's also other areas that have received less, but still some dosage. And here you can see that for this, in this case, there some of this other dosage was spared using the proton plan. So that's, yeah, but this is mostly an illustrative example.
Sure.
Yeah.
Okay. If I can add something.
Yeah.
So what you see on both pictures more or less is that the radiation in the tumors, so in the red circles, is basically equal. So that's the idea, so that the tumor receives the same type of same amount of radiation with both treatments, but that with proton therapy, you're able to basically focus your radiation on the tumor, or at least in areas close to the tumor. Well, with more standard radiotherapy, you see that also the areas surrounding the tumor that involve swallowing, for example, or saliva production, are also receiving radiation dose. So you could expect, in theory, more complications from standard radiotherapy.
Okay, all clear, thanks.
Yeah. Yeah, so, but yeah, so I'll stay at this slide for a bit. So, but there's also a difference in cost between the proton therapy and the standard radiotherapy, and also a difference in capacity. So, for example, in the Netherlands, there's now in total a capacity for around 2,000 patients a year. But the demand may be much higher. So for that reason, there's a, yeah, they want to know who gets the priority for proton therapy, and ideally you would want this to be those patients who benefit most from this. So in the Netherlands, they have this indication protocol, which has this criteria for or guiding clinicians to determine who is prioritized for proton therapy, via which the health insurance also covers this therapy. And the two criteria are that the patient should be at high risk for long-term complications, and the second criteria is that if they would use proton therapy, they are expected to have a much lower risk of complications. So they have an expected benefit of proton therapy in terms of complications.
And if I may, this limited capacity is because this technology is very new, but I think it's quite some years now that it has been proposed in hospitals. So will it always be extremely costly to equip, to buy this equipment, or is it because it's still experimental and the use is limited, so there were not many investments to reduce the costs? Or
Yeah,
so I would like to answer this question, but I don't know the answer to this question. So
maybe I can help a little too.
Yeah.
The thing is that it's not simply a device, or at least that's from what I know, but you actually need a whole facility, so a building basically, to provide proton therapy. So that makes that the initial installation of a proton device, therapy device, is quite expensive. I don't know the exact numbers, but I think it ranges between like 70 and 150 million euros ish. So in that sense, it's more expensive than a, like, say, standard photon therapy facility or device. So that makes it in the Netherlands now, there are currently 3 locations where proton therapy is provided, and those locations are chosen such that there are basically everyone in the Netherlands is somewhat in close proximity. I mean, the Netherlands is small, but somewhat in close proximity to a proton facility. And that means that in total, as Tuur said, there will be there's capacity for about 2,000 patients on a yearly basis to be treated with proton therapy, while it is expected from like early estimates that about 7,000 to 8,000 patients could potentially qualify for proton therapy. So that makes that there's a need for selecting those patients that would potentially benefit most from proton therapy. And that's why basically the strategy has been developed.
Yeah.
thank you.
Yeah, and as you can see, so in this or in this criteria, there's a large emphasis on the risk of complications, an estimated risk of complications. So, and that's what also what our research is about in HTX. So how do you estimate that risk reliably? I mean, and that's done with prediction models. And so to sort of give an image of what a prediction model, what it does more or less is, so prediction model gives the probability that someone would get long-term complications given the radiation plan. And this is done because by looking at different regions and then combining those, or the risk of those, into a risk of long-term complications. So it's so that's how that is done. And so I'm not going into too much detail about that, but what you could do then is for each plan make up calculate this risk. So, and then you can also look at the difference in risk between plans. So you could compare what is the risk of complications for a proton plan, or for this particular proton plan, compared to the risk of complications for this standard radiation therapy plan, for example. And if that is a large enough difference, so if there's a large benefit, then someone would could qualify for proton therapy. So and in the HTX project, so one important thing to notice is that these risk models are also based on patient data from patients who earlier received radiotherapy. And for those patients, you already know whether they received complications or not. And based on that, these models are developed. So they are used as examples to relate what regions are important for developing complications, which is needed to estimate the models. And then and in the project we're looking at how to best develop these models, and also how to evaluate them. So, for example, one question is how do you determine which region is important for developing complications, and how important the regions are. And another one is that often this data is not really as ideal as presented before, but there's some missing data as well. So this could, for example, be because patients passed away shortly after the therapy, but also for other reasons, and that could affect the model that you would develop using those data. So these are two questions that methodological questions that we address in the project. So this was kind of the presentation for now. So just to give a sort of intro.